Amazing grace.
Good morning, my lovely beauties. How we doing? How we feeling? Today is Monday. It is June the 15th. And just like I promised, I would take you along with me. Today is the day that I find out about my status of my breast cancer. So I got up, did my morning walk, and got dressed, and now I'm on my way there. So I will see you all shortly. Okay, beauties, I am in the room. I'm waiting to see the doctor. The practitioner came in and went over a few things with me, and now I'm in the hospital gown. And because I had on a dress, I had to wear something over my bottom area, but I am now just waiting to find out where I stand, what stage. And look at that hair, it just doesn't want to cooperate. But yeah, so this waiting stuff is hard. Like I'm remaining very positive, but it's like I just wish she would just hurry up and get in here so I can get this over with. That's what I'm feeling now. And my blood pressure was like super high. It's never been that high before, but they said that that's normal because of, you know, why I'm here. So yeah, so anyway, that is what's going on right now. Hopefully you can hear me okay.
Express too much of this Her2, they become candidates automatically. We know it even before we met. Candidates for the consideration of therapy that would target that receptor along with chemotherapy. That has a tremendous potential of not only dramatically reducing the tumor, but causing it to entirely disappear, which then makes, for example, saving the breast with breast conserving surgery by doing a lumpectomy far easier.
Okay.
So you could say, well, maybe I don't want that. Can I do a surgery first approach? And the answer is, of course you can. That same therapy is still going to be recommended afterwards. So it's not as if we're adding something that you wouldn't normally get. We're just changing the order that it's put into the recipe. Okay? So in any woman with HER2 positive breast cancer, which is what you have, if it's 2 centimeters or larger, so 2 centimeters is a little bit less than an inch, or larger, patients are automatically candidates for this upfront therapy. Okay? And I'm not trying to talk you into or out of anything, but based upon the fact that you have no family history, right now, I would love to be able to offer you a choice. And the choice is lumpectomy, by just removing the tumor with a rim of normal tissue, saving the breast, followed by radiation, which is every bit as equal to mastectomy. And you could say, wow, I really do want that breast conservation. Well, since we know that you're a candidate for that therapy after surgery, we just introduce it before to cause that tumor that we know you have to go from 2 centimeters, hopefully down to nothing. And it makes our job at the time of your actual surgery easier.
Okay.
So that would be radiation?
The therapy after the chemotherapy is surgery, followed by radiation if you save your breast. That's absolutely correct.
So I would do, if I do the what did you just, I'm sorry.
No, you're fine. We'll call it chemotherapy.
If I do that,
Yes.
and I do that, if I decide to do that before the surgery,
Yep.
if it reduces it or it goes away, I still would have the surgery?
Yes, ma'am, because our technology is such that we can never look at a patient and go, wow, microscopically your tumor is gone, we don't need to do surgery.
Okay.
We would do a physical exam, we'd probably get another mammogram prior to surgery in our patients who have the upfront therapy. And what we're hoping for is the radiologist puts on the report, they can't see anything except for the clip that's been left in the tumor. All that means is instead of going to the let's say you said, no, I want to go to the operating room now. I'm going to examine you, but we would probably have to take 2 centimeters, you need 1 centimeter on both sides, 4 centimeters worth of your breast tissue. If that 2 centimeters becomes 5 millimeters, instead of 4 centimeters, we're just taking 2 centimeters. So it makes our job easier for surgery because you lose less tissue. That's the benefit.
Okay.
And even in patients who say, let's say some patients come to me where they need, let's say you had, God forbid, multiple areas in the breast where I would only be able to offer you mastectomy.
Mm-hmm.
We still do the therapy before
Mm-hmm.
because it helps to shrink the tumors, making even a mastectomy easier.
Okay.
So, you know, we offer it 10 times out of 10. It doesn't mean that you have to accept. I would never offer it in a patient who I wasn't sure would need it afterwards. Why offer something before if they're not going to need it or weren't candidates for it anyway? That never would put a woman at risk for that. But I knew last night when I reviewed your chart that this is the conversation we would be having, strictly because you met two criteria. One, your tumor size is over 2 centimeters. 2, it shows the HER2 positivity. I don't do the chemotherapy. That's a medical oncologist. So I would set you up with a medical oncologist. And I also want to get, just because of the thickness of your tissue, you mentioned the lumpy, bumpy, dense breast, get a breast MRI to make sure that we're not dealing with anything else. They had mentioned some calcifications on the left, but I think they thought they were all benign. I'm not concerned, but the MRI gives nice clearance to the breast tissue and in making sure we're only dealing with the one mass. Okay. I know this is a lot to digest and a lot to hear. You don't have to make any decisions today. And we can certainly have you come back and talk with me if you're unable to make a decision as far as chemotherapy first or surgery first. If you were my wife, my sister, my mother, I'll tell you 10 times out of 10, I would do the chemotherapy first rather than the surgery first, then followed by chemo. My recommendation is always the chemo followed by surgery because you get better results. Okay? High blood pressure, seasonal allergies, some rhinitis, some nose, no family history from what you told Rebecca, from what I saw in your health questionnaire.
No.
That's great. Have you noticed any changes in your overall health looking back now over the past couple of months?
No.
No?
No. I mean,
Weight's been stable, no headaches,
menopause crap.
Menopause crap? That's a good label for it. It's a good label for it. Yeah, yeah. You do a copy of all of your path if you don't have it.
Okay.
So you could see the HER2 that's there.
Okay.
And we'll take next steps together.
Okay.
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 Okay. So I thought we're going to be fine, just like what I had.
And I will tell you, just to give you a historical perspective, I wholeheartedly agree with what you just said. You are going to be fine. Not to suggest, I'll never sugarcoat, I'll always give you the straight scoop. Chemotherapy is not easy, nor is it super tough.
Mm-hmm.
You'll have some symptoms that they'll go over. The key thing with HER2 is if we were all meeting 20 years ago, it was really concerning. It was scary. We know that these tumors, if you don't do anything, are more aggressive and can be more aggressive. With modern science and the new therapies that they have that target specifically the HER2, we actually now sort of semi-humorously joke that we think HER2 may actually prove to be better because we have more effective therapies for it than non-HER2 patients. So we have these therapies. If you took 100 women undergoing this therapy, anywhere from 50 to 80% of patients after the operation have no tumor found under the microscope. That's astounding. 50 to 80% come in with a tumor, get the therapy, have surgery, no tumor left. And those women do the absolute best. So,
and how does that work relative to reoccurring? There's no.
So while we're early in this, we believe the women who have complete response, either dramatic shrinkage or more importantly, complete response, do the absolute best long term. Does it mean a 0% chance of things coming back? No, no, but it really lessens the chances. And then specifically with HER2, and the med-onc would tell you this, you have your therapy before surgery, the chemo plus the HER2 agents, surgery. Then after surgery, no more chemo, but you still have therapy in their offices to treat the HER2. It's a cakewalk. There's no meaningful side effects, and they'll talk to you about that. But the chemotherapy is before, the HER2 therapy is before and after.